Ashley, do you hear me?
Yes, I hear you.
Yes. I think it started now, Ashley. So just when you connected, it started. So you can start to welcome everybody if you want to.
Fantastic. My apologies for the delay. Thank you everyone for joining and welcome to this ECDC World AIDS Day event on Redefining the Journey. I'm Ashley Furlong, a health reporter at Bloomberg, and I'll be a moderator today. Just a few house rules before we begin. Please ask your questions through the Q&A panel on your right of your screen, and the questions will be directed to speakers during the Q&A session. And please note that this whole digital event is going to be recorded and will later be available and shared on the ECDC's World AIDS page. There's been a lot of progress on HIV in Europe, with fewer diagnoses and fewer AIDS-related deaths. Yet, as new data released last week by the ECDC and the WHO shows, Europe is failing to test and treat early. And that puts the region in an incredibly precarious position and makes it less likely it's going to achieve the 2030 goal to end AIDS as a public health threat. And fueling those gaps are obstacles like stigma that's preventing people from getting tested and making it harder for people to access healthcare. And while we see that the EU and the European Economic Area are progressing, the wider WHO region is having a harder time. And today we're going to hear from our distinguished panelists, each of whom is an expert in their area. They're going to be setting out the data, telling us where we are and who is most impacted, and providing potential solutions and discussions on what Europe's future looks like. And to kick us off today, we're going to be hearing from Stella Bivol, Regional Advisor for HIV, Hepatitis and STIs at the WHO's Regional Office for Europe. She oversees regional strategies and technical support for ending AIDS and eliminating viral hepatitis and sexually transmitted infections. She brings over 20 years of global health experience, including serving as vice chair of the Global Fund's Technical Review Panel. And she will be showing us how new HIV diagnosis data for the WHO's region, and she's going to be setting that out now. Thanks so much.
Thank you so much for your introduction, and good day to everyone. It is World AIDS Day today, and it's an opportunity for us to come together to reaffirm our commitment to ending AIDS in a very difficult year, and actually building on years of and decades of progress that has not been even across WHO Europe. Still, there's a lot of achievements that we can celebrate today, as well as enumerate some of the challenges. So let me start from
Hi, I think Stella, would you like, I think you just cut off. Do you want to just start again? Thank you so much.
Yes, let me switch off my camera to have a better connection so that it can also focus on the data on the screen. We in this year we've just issued the joint report of ECDC and WHO Europe on summarizing the data for reported HIV diagnosis in 2024. And what the data shows is that we have around 106,000 HIV diagnoses that were reported by 49 countries of the 53 countries of the region. Around 70% of the burden is in the eastern part, with 27 cases per 100,000 population, compared to 6 in the western part and 4 in the central part of the region. And just to say, the region comprises 53 member states across 12 hour zones. What this data also shows is that we have predominantly transmission by among men, and the male to female ratio shows a pattern that is not typical for generalized settings, and it shows that a consistently low higher number of men to women potentially points to a misclassification of the actual transmission routes of the increased heterosexual transmission as well. The HIV transmission patterns also vary by sub-regions quite a lot. In the EU, EEA, and Western Central Europe, heterosexual transmission is increasingly reported, but sex between men remains the leading mode. In the East, heterosexual transmission dominates, but while still low, transmission among men who have sex with men more than doubled in the past decade, while injecting drug use has declined or continues to decline and reached a record low rate of 18% in the East. So the other point to make in this table is that the percentage of people who are born outside the country where they were diagnosed or reported as diagnosed is quite variable across the region, with percentage of migrants being 57 in the West, 15 in the center, and just 2% in the East. So moving to the next one, just to say that there has been an increase in 3 consecutive years in 2021 to 2023 in terms of the rate of reported diagnosis after rebound after COVID. But this year, there's a 8% decline compared to 2023 in terms of actual reported diagnosis. And this actually is a increasing gap between the estimated number of people who acquire HIV infection and those who are actually reported as HIV diagnosis. This is a highly variable pattern again. There's quite a variation among sub-regions and in terms of also countries, and a lot of it is actually attributed to a decline in the reported HIV diagnosis in the Russian Federation overall across WHO European region, whereas in the EU, EEA, the number of diagnoses actually are higher than the estimated infections, showing that the gap is closing in those parts of the region. So moving to the next one, the HIV diagnosis per 100,000 population, they have declined in 2024, and the trends still remain heterogeneous across sub-regions and countries, with 7,000 people, around 7,000 people diagnosed in 43 countries with AIDS diagnosis. And at the same time, in the 39 countries with consistent AIDS data, the overall rate of AIDS diagnosis in the region decreased by 53% between 2015 and 2024. I think this made the headlines and it's still, unfortunately, consistently the same message that we have for the last decade or more, that late diagnosis remains widespread across the WHO European region, with over half of new diagnoses occurring with CD4 counts below 350 cells per, which means advanced disease and the late presentation. And the highest rates of late diagnosis are seen among people with heterosexual transmission and those who inject drugs, while the lowest in people who have been with men who have sex with men transmission route. Also, older adults are more affected, and higher percentages in women compared to men. So, just a few words on the treatment cascade. Timur from ECDC is likely to present the cascade based on the Dublin Declaration, but this is the treatment cascade in 2023 of based on UNAIDS and WHO estimates that shows the first 95 as people who know their HIV diagnosis being at 78 across the region, with large variation between the regions, and the lowest number of people who know their HIV diagnosis being in the East at 72%. And also second 95 is still quite low. And first time this year, we don't have data available for the last 95 due to unavailability of data in countries with low burden. So just a few conclusions. So we see a growing gap between new infections and HIV and the diagnosis, representing an increasing number of undiagnosed people, especially in the eastern part of the region. We're seeing decline in HIV diagnosis, but this decrease is largely driven by the Russian Federation and may partly reflect reporting artifacts and highly heterogeneous across the region. We are seeing different transmission patterns by sub-region. While heterosexual transmission is increasing overall, the transmission route of sex between men remains predominant in much of the center and west, especially among diagnoses born in the reporting country. Late diagnosis remains common, and we also want to point on data gaps and incomplete reporting. So for this, we highlight the importance of scaling up targeting testing, prevention, early treatment, and migrant-inclusive services that are remaining essential for the reaching the 95 targets. Just a few words on policy adoption and implementation status in the country. While we are seeing specific information on reported diagnosis, at the same time, when we see at we look at the policy adoption, the picture is quite positive because many of the countries, almost all, have already adopted the dolutegravir as the first preferred line regimen. In fact, 50 countries of the 53 member states transitioned to dolutegravir-based first-line regimens as preferred regimens. We see many more countries committed to having plans for eliminating vertical transmission of HIV and syphilis. We do see quite many countries having national needle and syringe programs and opioid agonist therapy in their programs directed for people who inject drugs, but obviously coverage and service and sustainability varies, and many countries report low coverage. We are seeing that many of the countries have HIV prevention, treatment, and services in prisons, and but again, coverage and comprehensiveness of these services varies widely. For testing, many countries have adopted self-testing policies and community-based testing, but we do want to see this taken at scale as fast as possible. I think I will conclude here with just a few words on 2025 and the WHO work in 2025. 2025 is a year of disruptions, global health architecture changing, yet many of the breakthrough technologies still happening this year. So for us, it was very important to issue the lenacapavir PrEP as an additional option recommendation, and some of the guidance that you see here is centered around overcoming disruptions, maintaining essential services, ensuring uninterrupted services, at the same time sustaining and transforming services through integration in general health services, as well as for example, with non-communicable diseases. And very important to address stigma through rights-based and non-discriminatory services, as well as keeping communities at the center. I thank you for your attention.
Thank you so much, Stella. We're going to be diving into some of these topics in just a little bit. But now we're going to be hearing from Taimur Nuri. He's an expert on communicable disease prevention and control at the ECDC, and he's responsible for monitoring the HIV response in Europe and assessing how countries are progressing towards the Sustainable Development Goals for HIV. And Taimur will present the new data on where we are in terms of reaching targets such as those on PrEP and mortality. Over to you.
Thank you so much, Ashley. So I have the privilege to present some new data that we published last week, some of the data together with WHO, and I have no conflicts of interest to declare. What I would try and focus on is some of the key targets that we're monitoring towards the SDGs in 2030. The data I'm going to be presenting on centers around pre-exposure prophylaxis, the testing and treatment targets, HIV incidence, mortality, and stigma. And at the very end, I'll just try and show you an overview of where Europe is in terms of these targets. So starting with the first data batch I have around pre-exposure prophylaxis, data that was published last week. This shows you the status of former PrEP implementation across Europe and Central Asia at the end of 2024. In dark green, you see the countries that have actual guidelines implemented and nationally funded programs. Where there's basically no out-of-pocket spending. The lighter green shows you 11 countries that have guidelines implemented, but it's not fully funded. So there is out-of-pocket spending anywhere from 3-4 euros up to 60 to 80 euros, depending on which country we're talking about. And then the rest of the countries, basically no formal PrEP implementation is going on. This was published last week based on data at the end of 2024, but there's already new things happening. We have PrEP now implemented in Greece as of April, May this year, a very successful program. They're scaling up rapidly. Cyprus has also implemented a program as of a month or two ago, which is great. Lithuania has also implemented a PrEP program in November, I think it was. And Romania has also now made a decision to start implementing PrEP as of 1st of January. So this is great to see that countries are moving towards PrEP implementation across the region. This shows you the number of people receiving PrEP at least once in 2024. On the far left-hand side, and keep in mind that this is a log scale, on the far left-hand side, you see the countries with the highest actual number of people on PrEP. So that's the United Kingdom, France, Germany, and Spain. And then falling into descending order, you see the countries that have provided data to ECDC. The target that WHO has is that at least 500,000 people should be on PrEP at the end of 2025. We have talked about this. I think it's a bit, we need to revise this target up a little bit to have a bigger impact across the region. But nevertheless, we are at 350,000 people that received PrEP at least once in 2024. So we're quite far off reaching this target. Another problem with this target is that out of those 349,000 on PrEP, 70% of those reside in these four countries, the UK, France, Germany, and Spain. So we have quite huge inequities in the implementation of PrEP across the European region. Another issue around PrEP equity is who's receiving it. Here you see the percentage of subpopulations receiving PrEP among all PrEP users. So not all countries are able to disaggregate their data, but if you look at the green bar, when it comes to men who have sex with men, 27 countries are able to disaggregate the data. And in those 27 countries, 88% of all people receiving PrEP are men who have sex with men. That drops to 24% when it comes to migrants. And we know that migrants is a really important issue, especially in the EU, where 56% of diagnosed cases are among people who are born abroad. But when it comes to implementing PrEP, very few are receiving it. And it gets even fewer when we look at people inject drugs. Women, only 3.4% of people who are receiving PrEP are women in the 29 countries that are able to disaggregate the data. 3% are sex workers, and only 1.5% of the countries that have data are transgender people. So we have PrEP inequity between countries, but also within countries when it comes to subpopulations accessing it. And there's a lot of work trying to address this issue, but it's something that we need to work on even more. So moving on to the testing and treatment targets, you're all very familiar of these 95% targets. I'll go through the data of each point, but I just want to reiterate that individual countries can do quite well on these targets, the first, second, and third one. But the really key important aspect is actually to reach 86% viral suppression of all people living with HIV. That's the modeling that UNED says that we are on track to end AIDS if we reach that target. So that's the key here. But let's look at the data for the first 95. So looking at all people living with HIV who are aware of their HIV status, we have great data here from 46 countries. You see the red line shows you the target of 95%, and the black line shows you where we are currently in Europe. We're at 86% that are aware of their HIV status. You see the green countries, or the countries in green bars there, 10 countries have actually reached the target already. Another 15 countries are within 5%, so we think they are able to reach these targets. And then in orange, 21 countries are more than 5% away from reaching the target. And so that is the data point for the first 95. Moving on to the second 95. So once you are diagnosed, are you receiving treatment? And we know that most or all countries in Europe now have a test and treat policy that once you are diagnosed, you should be put on treatment. So we've done the hard work of diagnosing people, and now we should be putting them on treatment. Yet we see here, we're at 86% here as well. You see the range there in parentheses between 52 and 100% are on treatments once you've been diagnosed. So this is a target that we are lagging behind as well. And finally, once you are on treatment, are you reaching viral suppression? We know that treatment is very effective, and usually within 6 to 12 months, you should be reaching viral suppression. And this is actually a target which we have reached in Europe as a whole. You see we're 95%, but there is a range there as well from 69 to 100%. So more countries, a lot of countries have reached this target already, but there are some that are falling behind. So as I said, the key really is this 86%. Do you have data across all these things to measure the number of people that are virally suppressed out of all people living with HIV? Here we have 38 countries out of the 55 that report to ECDC that have data on all these steps. And we see here the target, red line, 86%. We're at 70%, so we're quite far away from reaching this target. Again, the range is from 42 to 100%. 14 countries out of 38 have reached this target, but more than 20 are actually quite far away from reaching this target. So this is going to be a major challenge in our region. And also worth mentioning, 17 countries are actually lacking data to measure their overall progress towards these targets. So this 70% average could be an overestimate, because typically if countries lack data on a certain issues, they also tend to be in certain areas, those countries that are falling a little bit behind. So that could be an overestimate. But WHO and ECDC are working with these countries, trying to support them to have data across all these steps. On to stigma. This was mentioned by both Stella and Ashley on the importance of stigma. We have really good stigma data now, finally, which we've been lagging for all these years. I'm just going to touch on a few data points on stigma. So this shows you the percentage of people living with HIV who have never told any family member, friend, or current sexual partner about the fact that they were living with HIV. On the left there, you see that 30% have not told a single family member that they're living with HIV. And I wonder what that percentage is for other diseases, but this is very, very high. And that's what separates HIV, the level of stigma associated with it, right? And I hope we can talk a lot about that today. 19% have not told a single friend, and 22% have not told a single current sexual partner that they were living with HIV. This shows you the experiences of stigma in healthcare settings among people living with HIV. So if you look at the red and orange, a third, 33%, are actually worried about being treated differently by healthcare and staff. A third of respondents were worried about being treated. And half of those, in red and orange here, 18%, actually avoided healthcare because they were expected to be treated differently. So it's very important and shows you the fear that people living with HIV have. They expect to be treated differently, and they actually, to a certain degree, avoid healthcare altogether. And that's why we partnered with the European AIDS Clinical Society to try and measure stigma in the healthcare setting, and we have really good data around that. I just want to show you, the first thing we did was trying to measure the knowledge of some key concepts around HIV transmission and prevention among healthcare workers. And we had over 18,000 healthcare workers across our region who responded to the survey. And as you see here, 39% of them did not know what U equals U is. 44% had incorrect knowledge around post-exposure prophylaxis. And almost 60%, 6 out of 10 respondents, did not know what pre-exposure prophylaxis is. So there's some work to be done here to educate people in the healthcare setting around these these key concepts because we know that knowledge is associated with levels of stigma. So the lower knowledge you have in a setting, the higher potential for enacted stigma in that setting. This shows you what the healthcare workers themselves said, that if they've observed stigma and discrimination towards people living with HIV in their own workplace during the past 12 months. So here we see 18% of respondents said that they observed poor quality of care given to a person living with HIV at their workplace in the last 12 months. 19% had observed disclosure of somebody's HIV status without their consent. 22% had observed unwillingness to care for somebody living with HIV in their workplace in the last 12 months. Remember, this is in the last 12 months. Oops. And then 30% had observed discriminatory remarks towards people living with HIV in their workplace. So still high levels of stigma in the healthcare settings across our region. So moving on to incidence, HIV new infections. This shows you the incidence target. The red line shows you all 53 countries in Europe and Central Asia and the WHO European region. The blue line shows you the 30 EU EA countries. And the target says that we should see a 75% reduction in new infections by 2025 and a 90% reduction by 2030. So you see the red line, 149,000 new infections were estimated in 2010. And we're actually seeing a 5% increase in WHO region as a whole, not a 75% reduction. The blue line shows you that we are seeing a decline in new infections in the EU, a 20% decline, but that's very far off the target where we need to be this year. So clearly, this is a target that is very important. It shows you the overall progress on prevention, testing, and treatment programs, and we're very far away from reaching the 2025 target, and it looks very unlikely that we will reach the 2030 target. Mortality is an issue that we are working together with WHO and UNAIDS to estimate. This shows you the progress towards reaching the AIDS-related mortality target. Again, the target is to see a 90% reduction in AIDS-related deaths by 2030. You see that the red line, 37,000 deaths were estimated in 2010. And here we're actually seeing a steep increase, 37% increase since 2010. We are seeing a big decline in the EU EA countries of 47%, which is positive, but is still far away off the 90% that we need to see by 2030. So major challenges on the mortality as well. So to conclude, which targets are in reach in Europe and which will we struggle to make? Showed you the PrEP data. The target says 500,000 people on PrEP, which I think is too low, but we're still at 349,000, and that's the target that's not in reach by 2025. The first 95 out of diagnosing people that are living with HIV, we're at 86%. Year on year, we typically see around 1% increase in this, and we're at 86%. So we're quite far away from reaching this 95% target, potentially 9-10 years. So that's not in reach. The second 95, once you are diagnosed or you put on treatment, we're at 86% here as well. We're not going to reach this target. The third 95, once you are on treatment, will you be reaching viral suppression? We know that treatment is very effective, and that's actually a target that we have achieved in Europe. But the overall target is the key one here, viral suppression among all people with HIV. We're quite far away from this. We're at 70%, which could be an overestimate, clearly not in reach. Stigma and discrimination, we have lots of data on all aspects of people living with HIV who experience stigma and discrimination, and in healthcare settings, and in every indicator we have, it's above 10%. So clearly this is probably one of the most challenging indicators we will have to reach going forward. New infections, I showed you, we need to see a 75% reduction. We're actually seeing an increase of 5% in the region, not in reach. And finally, when it comes to mortality, we need to see a 90% reduction by 2030. We're actually seeing a significant increase in the WHO European as a whole, clearly not in reach. So I just want to end with, when you look at this, it looks quite striking, but it's very important also to just mention the issue of inequities in our region. We have countries, especially in the western parts of the EU and the EU countries, that are doing quite well and are reaching many of these targets. But the further east we go, the poorer the outcomes are on whatever indicator we're looking at. So this is an important message that I hope we come to, that some countries are doing well, others are not, and how do we address that issue going forward? So a lot of people online here, a lot of people that provide this excellent data to ECDC, to WHO, that need to be acknowledged. as well as colleagues from University of Copenhagen who help us with some of this analysis, with UNAIDS colleagues, WHO, Stella and her team, as well as colleagues here at the ECDC that I want to thank. So over to you, Ashley.
Thank you so much. We are also going to get to some of these points again shortly in the Q&A section. And just a reminder to everyone, please put your questions in the chat. As a presenter is speaking, if you have any thoughts on it and you want to ask a question later, just pop it in there and then I'll get to it in a little bit. But now we're going to be looking at redefining what success looks like, and we're going to be assessing what standards we should be expecting today. And first, we're going to be hearing from Jürgen Ruckschro. Jürgen is a professor of medicine and head of infectious diseases at the University Hospital Bonn. He's both a clinician and a researcher, and he's been investigating multiple clinical trials of antiretroviral agents and treatments for HIV, hepatitis, co-infection, and COVID-19. He's also the chair of the EACS guidelines. Jürgen will talk to us about his view from a clinical perspective. Over to you. Thank you.
Thank you, Ashley, and welcome everyone for joining this webinar. So I think what became clear already in the first two presentations is that there are really huge inequities between various regions in Europe. And that refers to many different aspects around testing, prevention, treatment access, and how we manage people living with HIV. So clearly there is an idea to develop standards of HIV care. So really kind of saying that everyone who lives with HIV should, regardless of where he or she is from, should receive the same level of care. And that would then need to be defined. So HIV standards of care refer to the set of guidelines and best practices for the prevention, diagnosis, treatment, and management of individuals living with HIV. They're based on current scientific evidence, clinical research, and expert consensus to provide optimal care and improve health outcomes for people at risk for living with HIV. The standards translate existing guidelines into measurable policies and practices that can be monitored and audited. Now, remember that the EX guidelines, which are updated every year, were just updated and presented at the EX conference, and they really contain a huge amount of information. And that is particularly true around the area of comorbidities, because obviously in 2025, it's not only about being tested, put on treatment, and become undetectable, but it's really about reflecting on the fact that almost 90% of all HIV diagnoses are occurring in people aged over 50, and that in Western and Central Europe, the proportion of people living with HIV aged 55 years and older will increase from 34% in 2020 to almost 50% in 2030. So with that increasing amount of individuals getting older, obviously comorbidities become a main focus of clinical care in everyday practice. And with increasing life expectancy, people living with HIV will face a growing burden of non-communicable diseases, which already have been addressed in previous talks, including cardiovascular disease, diabetes, and particular cancers. Remember that non-AIDS defining cancer is now the main cause of dying in someone who lives with HIV, chronic renal, liver, and pulmonary disease, as well as mental neurocognitive disorders. People living with HIV have a much higher risk of developing a non-communicable disease. It's 42% versus 23% in the non-HIV cohort. And it's projected that up to 84% of people living with HIV will have at least one non-communicable disease, with 28% experience 3 or more in the near future. And the reason for that is that we believe that even in the setting of controlled HIV replication, there is still higher immune activation as a result of the exposure of HIV antigens to the immune system, and that inflammation can cause, for example, activation of cells, which then play a role in the formation of atherosclerosis, for example. Now, the overall attempt between EX and ECDC has been to develop modules around various topics in the HIV area to sort of develop guidance and standards of care for certain areas. And one of them is comorbidity, and that has just been released. So the module comorbidities has just been published on the ECD website. And it really is divided into various topics, including prevention and management of cardiovascular disease, cancer screening, mental health, general screening for chronic diseases, aging and people living with HIV, lifestyle interventions, monitoring, and evaluation. And a quality statement, for example, would be that anyone living with HIV should have a cardiovascular risk assessment and a modification of risk factors which may contribute to cardiovascular risk. And an indicator would be to see how many of people above age 40 living with HIV in a given practice or clinic would have been assessed for cardiovascular risk. and that should be at best be above 90% if you want to have a good standard of care. And I think the attempt is to really bring some of the other health issues of people living with HIV into the forefront and make sure that impending issues, in particular cancer screening, cardiovascular risk assessment, and mental health, become more appreciated and are integrated into the general care of people living with HIV. And that may be very different depending on which healthcare setting you come from, because, for example, statins may not be prescribable by ID physicians who take care of people living with HIV in certain states, or some family doctors may be more prone to take care of this, but sometimes it's really the HIV physician who has to handle all these other comorbidities, and sometimes stigma and discrimination plays into this because people are afraid to present at other doctors other than the one they have in their HIV clinic. So I think all of that together really is a big attempt to improve the care in an aging population living with HIV, and to make sure that some of the bigger challenges ahead, including cardiovascular risk and cancer occurrence, which seem to be increased in people living with HIV, are addressed properly and in a good way and manner. Thank you very much.
Great, thank you so much, Jürgen. We'll get back to you in just a little bit, but we're going to now have Olena Strizak. Olena is a long-term survivor of HIV. She began her work as an advocate for the rights and well-being of women living with HIV, particularly HIV-positive pregnant women in Ukraine in 2002. And in 2015, she co-founded the Eurasian Women Network on AIDS, and she leads the Positive Women in Ukraine, the only national network of women living with HIV. Over to you, Elena.
Thank you so much, and thank you for invitation me as a speaker here, because if we're talking about quality of life, people living with HIV, I can say that in Ukraine it's a different one, and I would like to share with you some numbers also from our research. This results of the community-led research, the impact of war on women living with HIV in Ukraine, which we finalized in 2024. The need for constant mental health support, humanitarian aid, and information support is confirmed by the barriers to seeking medical, social, and legal services mentioned by almost 70% of women. Self-care has taken a backseat compared to other basic needs. Financial inability, 62%. Lack of information about services, almost 60%. No energy to ask for help, 53%. The geographical remoteness of service provider, travel takes a lot of time and or money, becomes an obstacle for almost half of the interviewed women, 47%. This also applies to participants of OST programs who, in addition to the geographical remoteness of the medical dispensing facility, noted the need for frequent visits to these facilities. Caring for children and other family members is obstacle for 44% of respondents. Fear of stigma discrimination due to the HIV positive status remains a problem in seeking help for 42% of women living with HIV. Primarily for migrant women and IDPs, internally displaced person, loss of familiar surroundings and support, 45%. Lack of friendly HIV medical professionals, 41%, and HIV services, non-government organization, 39%, also became a significant barrier. The research demonstrated how the combination of several of these factors, along with living under constant shelling, can lead to ART discontinuation. And also, I have some numbers from the rapid assessment from AIDS Healthcare Foundation in Kiev, which was organized on behalf of healthcare providers. 83% of healthcare providers believe that the full-scale war in Ukraine has affected the RT interruption. More than half of them, 57%, believed that this was due to migration, including abroad, which caused their clients to not know where to ask for help or not to trust doctors. 33 of respondents reported that RT interruption was associated with depression and stress. In addition, healthcare providers indicated mobilization into the armed force of Ukraine as the reason for interrupting therapy in 15 of cases. About 13% of healthcare workers believe that RT interruption were influenced by both the worsening financial situation of the population and the increase in alcohol and drug addiction. Deterioration of logistic and healthcare system 9%, lack of communication 5%, and being in occupied territories 7% were also among the main reasons. Among the main reasons for RT interruption related to the war in Ukraine are migration, worsening mental health, decreased living standards, being in the armed force or not wanting to join them, and increasing addictions. Thank you.
Thank you so much, Elena. We're now going to head to Ricardo Fernandez. And Ricardo is an activist and he currently serves as the Deputy Executive Director of GAT, an organization that supports communities vulnerable to HIV, viral hepatitis, TB, and other STIs through peer-led sexual health and harm reduction services, as well as national and international advocacy. He's been active in the field since 2000, and he's former chair of the European AIDS Treatment Group. He's also co-author of studies on stigma, late diagnosis, and health literacy. And Ricardo is going to discuss what a person living with HIV could expect in terms of high quality care and excellent quality of life. Thanks so much, Ricardo.
Thank you, Ashley. Many thanks to ECDC and Timur for the invitation to be at this event. As someone who has lived with HIV for 25 years, it's very special to be here in the World AIDS Day. And at a time when so many exciting advances are happening in treatment and prevention, but unfortunately when we are also witnessing disinvestment and lack of political leadership to end HIV as a public health issue. But I want to begin with a simple truth that too many people still never hear. Living with HIV today, it's not living with a sentence, it's living with a possibility. A possibility for a long life, a full life, a life that deserves dignity, respect, joy, and a future. And I say this not only because science has proven it, but because people living with HIV themselves repeat it again and again when we finally listen to their stories, their fears, their hopes, and their dreams as well. Research that actually centers their voices, like the people living with HIV stigma index, GNP plus community reports, they all tell us the same thing. People living with HIV want what everyone wants: health, love, security. A life where they can make plans, a life where they can dream without fear. The good news is that thanks to modern treatment, this is possible, completely possible. Today, we know that when someone takes their medication and maintains an intact viral load, they can live as long as anyone else. Large studies from around the world all show that life expectancy for people with HIV it's the same and approaches largely from the general population. And there is a moment that many describes as life-changing. For me, it was the moment that they learned that undetectable equals intransmissible. The moment they realize they cannot pass the virus to their partner. The moment when the shame and fear begins to lose their grip. The moment when hope becomes possible again. But living well is not just about medication. It is about care that listens, care that welcomes, care that understands that health is more than lab results. It is the mind, the heart, the relationships, the ability to feel whole and not reduced to a diagnosis. When we listen to people living with HIV in clinics, in community groups, in research studies, we hear the same honest, powerful requests. See me as a person, support my mental health. Don't leave me alone with my stigma. Respect my sexuality, my relationships, my right to have a family. Don't treat me as an exception, treat me as an equal. That is what high quality care means. That is what living well means. High quality care is fast and easy access to treatment. It's simple, safe, modern regimens, including long-acting injectables that fit into real lives. It is health professionals who speak with people, not about them. It is mental health support, trauma-informed care, and spaces that are free from judgment. It is understanding aging with HIV and monitoring other conditions, the heart, the bones, menopause, mental health. It is sexual and reproductive health that is respectful and affirming. And it is community and peer support. People who say, I've been where you are not alone. Because despite all the scientific progress, stigma is still the heaviest burden people living with HIV carry. Stigma hurts more than the pill. Stigma isolates more than a virus. And this is why listening to the lived experience of people with HIV is essential, because those voices show us clearly where the system fails and where society must do better. The truth is simple. With treatment, emotional support, community, and dignity, a person living with HIV can build a life as big as they want. A life with love, a life with work, family, and purpose. A life with laughter and aging and dreams that, refuse to die. A person living with HIV today can expect health, they can expect freedom, they can expect safety, they can expect relationships that are not defined by fear, they can expect the future, a long and meaningful one. And what we as professionals, as policymakers, communities, and human beings have the responsibility to guarantee is that every person living with HIV is treated with respect, that every person living with HIV has access to the best care, people living with HIV has a safe place to be themselves, and every person living with HIV knows that they are not alone. Because today, thanks to science, to community, and to the courage of people who refuse to be silenced, living with HIV, it's above all living a whole life, a dignified life, and a life full of future. Thank you.
Thank you so much, Ricardo. We're now going to move to the discussion part of the event, so all other panelists will join us. And just a reminder again to put your questions in the Q&A box. I already have a couple there that I'm going to get to shortly. I thought we'd start with, with the most recent data on late diagnosis. We know that 54% of diagnoses in the region are coming too late. Stella, I'm wondering if you could outline, who exactly is being diagnosed late and point to some of the reasons for that.
Thank you for your question. We'll start from age and age distribution. It does increase with age. Actually, the groups that are mostly diagnosed late are people over 40 or 50 years old. It also affects more the people who are not born in the country they were diagnosed. So it actually shows barrier in access to services.
I think we just lost Stella. Stella? Okay, we're going to come back to her. Timo, I'm wondering if you could, explain the varied picture. Oh, sorry, Stella, are you back?
I'm back, but please go ahead. Apologies for my connection issues.
I can hear you well now, so maybe if you just try without the camera.
Yes. I mean, I'm not sure when you lost me, but it basically increases with age, and it also increases for people who are not are reported as positive, not in the, or diagnosed as HIV positive, not in the country they were born in. So it actually shows the importance of universal coverage and the importance of making services available to everyone residing in a country, regardless of documentation status. And at the same time, it also shows the importance of testing in places that were not conventional before. So testing outside health facilities, improving self-testing, access to self-testing, improving access to community-based testing, and also in some areas in general health services and in emergency departments are some of the ways to reach out to people who are not diagnosed.
Great. I'm going to get into some of those testing and different sort of alternatives to testing in sort of traditional healthcare settings in just a little bit. But Timo, I'm wondering, the very picture around the region. You mentioned that it's a very different picture in the east and in the west of Europe. Can you zoom in on places that are particularly concerning? And what are some of the factors that are impacting that in those particular countries? And then maybe also, what's being done to try sort of fix and solve those problems. Whether it's community-based testing or self-testing?
Yeah, that's a very broad question. Actually, it basically touches on everything, right? So on every outcome that we have data on, we have the same pattern where it looks better in the West, and it's kind of a gradient map that the further east we go, the poorer the outcomes. And that's a very general statement, because there are some countries in the eastern part of the region that are doing great work. Ukraine is an example, which is really scaling up PrEP provision, for example, reaching key populations despite the situations they are in with the war, right? And they're doing great work. In Georgia, there's other examples, and Kazakhstan also increasing PrEP coverage, etc. So it's a very general statement, but if you look overall with the data, that's kind of the pattern that we're seeing. I think to answer your question, basically it touches on everything, right? From prevention, access to prevention programs, to testing the right people, to putting people on treatment. We see some countries in the East which are testing a lot of people and diagnosing people, but then miss on the second step, to put people on treatment, right? I think ultimately, and I'd love to hear what Ricardo and Olena say, but ultimately I think it's about political commitment, right? What political commitment do you have to address these issues around vulnerable populations, on access to services for vulnerable populations? That's a key issue that I think that needs to be addressed. There is testing, as I said, but then committing to putting people on treatment, to implementing the guidance that they've already signed up to providing PrEP and other opioid substitution therapy and needle exchange programs for people who inject drugs is a matter of choice, and in some countries that they don't deliver on that choice, right? So it's about political commitment on many of these issues. But and that brings me to the last part of the answer here is around stigma. Why isn't there political commitment around these issues? And ultimately, I think it comes around stigma. The stigma data that we were able to capture shows very clearly that in many of the countries with the highest burden, with the highest incidence of new infections, is also the same countries that have the highest levels of stigma, both in the community but also in the healthcare setting. We don't have stigma data among political leaders, but I'm sure it will show the same thing, that the higher levels of stigma, the higher the lack of knowledge of HIV and around vulnerable populations, the poorer the outcomes. So it touches on everything: prevention, testing, treatment, but ultimately it's about political commitment and stigma, I would say.
Thank you so much. Maybe just to come to you, Olena, we're obviously in Ukraine. The situation, has started out incredibly complicated, and now we sort of reached this new normal where care is still being provided in as much as it can be in a very complex situation. I'm wondering, could you what Timo said about political will? Do you think that political will is there? And could you just sort of describe what this new normal has almost become like in terms of accessing HIV testing and prevention and treatment care?
Yeah. I would like to add some words from Ukraine to Timur what he's mentioned, yeah, I agree. Despite the fact that we have full-scale war, full-scale, and 11th year this war was started, and despite the fact that in 2025 a global historic funding crisis occurred and HIV prevention services were seriously disrupted worldwide, the Ukrainian patient communities strives to demonstrate the resilience of the country and communities, which are intensifying efforts to protect the achieved successes and promote response measures. In Ukraine, during a full-scale war on HIV, testing and prevention and treatment programs remain accessible. Therapy is lifelong and free of charge for patients, for all people living with HIV. And I have some information about epidemic in Ukraine. According to the Center for Public Health of Ministry of Health, today Ukraine ranks among the countries of the European region in terms of number of HIV positive people. Every third HIV positive person still either does not know their HIV status or remains outside the scope of medical supervision and accordingly does not receive treatment, ARVID therapy. As of November 1st, 2025, 133,382 people are registered in healthcare institutions that provide medical supervision for people living with HIV, and also 115,336 HIV positive Ukrainians are receiving ARV therapy, while in 2009 we had 15,871 people. You can see these differences of the numbers of people who received ARVs. Therapy allows people with HIV to live. Despite the war in Ukraine, there are options available to get tested for HIV from your family doctor or infectious disease specialist. On the basis of public organizations also, HIV testing in Ukraine is free. I remind you that the main route of HIV transmission remains sexual, 68%, mainly through heterosexual contact.
Thanks, Elena. Ricardo, I wanted to come to you now. We've heard, just what Elena just mentioned about heterosexual transmission, and we saw earlier in Stella's, slides around how this is particularly among male heterosexual transmission. And I'm wondering, are there particular initiatives that you think might be particularly effective in targeting this population group in terms of, we seeing sort of this number of late diagnosis is particularly worrying in this group, and I'm wondering, if interventions that have worked for other population groups might also work here.
Thank you, Ashley, for the question. It's a very important question when we look at the numbers today. Even in my home country, Portugal, that's the reality that the report was just presenting a couple of days ago. Well, I think that we should look first who are these heterosexual men. And I think that we will probably see that a lot of them, they are coming from communities that are not very, that don't have access to treatment and prevention. And so it overlays a little bit with what Timur was saying. So we need to make sure that some of the communities, they have access to treatment. So when they treatment and prevention, we have some settings where migrants, for instance, I was thinking on migrants, they don't have access to PrEP. And although numbers are looking better, they are far from allowing us to have an impact on public health. So I think that one of the things that we need to do is to expand what are already the good practices, around community work that are very capillary when reaching some of these communities. They need to be empowered and reinforced in their tools, because there's a lot of work being done that has results, but it's not enough. So I think that a lot of the things that we need to do is only scale up what we are doing, like PrEP and also outreach work to some of the communities. So if we can scale up, I think that we can have better results. So I think that, and we've heard all these specialists today, we know what to do. We just need political leadership and more resources in the field.
Jürgen, you have your hand raised. I actually had a question for you about migrants, but I'm thinking you actually might be coming in on that. I'm going to hand over to you.
Yeah, so I think there's one important thing, though, to say, that a lot of the people which are diagnosed late do not perceive themselves at risk. So even if we empower communities, I think that may not be enough. And I think if you look at the emergency room testing initiative, which started in the UK, but has also happened in other places like Spain, for example, and their model projects in many other countries, have highlighted that indeed in that particular effort to screen everyone who's taken a blood sample when presenting in an emergency room, who gets then tested for HIV, hepatitis B and C, you find a huge range of people with new diagnoses, particularly for hepatitis B, but also for HIV. And that includes exactly the people who are now reporting more infections in. So these are older people, these are heterosexuals, and that tells you that you can also reach people who may not necessarily have perceived themselves at risk or were not comfortable with the testing services they got offered. And if you look at the 95, 95, 95 goals in the UK or in London, for example, a very diverse city, you can see that they have achieved the 95, whereas in other countries, this is not happening. And Germany would be one example where the first 95 in particular is a challenge. And that has a lot to do with, for example, that there are different testing policies around consent prior to testing. So remember that in the emergency room, it's opt-out testing. So people are informed with a poster or a display that this sample will also be tested for HIV unless they say they don't want that. Whereas in the German context, for example, you have to have a document written consent, which is a whole hurdle and barrier in testing someone in the emergency room where there's just so much going on that no one has the time to perform this kind of service. So I think there are ways to improve. And I think one thing we really need in Europe is that we learn from the good practice examples and transfer them into all the different countries to make things sort of happen everywhere. Thank you.
I'm going to come to Ricardo in just a second, but Jürgen, I'm wondering, how difficult it is to actually get those policies, implemented and to get them, through whether they need a legislative process, and obviously that'll depend on each country. But is it a politically difficult thing to get through, or was it actually quite straightforward very often?
Yeah, well, so in the UK, I think there was a great working together between community and emergency doctors plus other stakeholders in the HIV area. And in Germany, there is a big reluctance to get away from the documented consent, written consent, which is a big barrier. The same is true for Italy. And that is, but also partially coming from the community in this particular part. And we've had roundtables with the health ministry and with the community representatives. We invited representatives from the UK community, people living with HIV, very strongly expressed how much that changed their access to get people tested and how that has improved. They're achieving 95, 95, 95, and still that has started a discussion, but unfortunately not changed the practices. So this is one of the big challenges we're facing.
Thanks. Over to you, Ricardo. You had your hand up.
Yeah. I just wanted to add, to say that I completely agree that with what Jürgen said, ER and other tools, we need to use it all. But I was thinking as well on self-testing. There's not a lot of enough self-tests being distributed around Europe, and I think that has a role as well. But ER tests, as my good friend Katarina Sanz is saying on the chat, it's a very good thing, but we need to work also on linkage to care. And I was thinking that all the work that we need to do with some populations to link them to care and retain them to care. So this is a very important thing, because we have a lot of support to test, or some support, or at least support to test, but we have almost zero support to link people to care. and to support them in their journey to stay in care. So I think that this is something important if we want to also stop the epidemic and how it works in terms of infections.
I'm going to come to Jürgen in just a moment, but just wanted to sort of put it into context, the self-testing question really, and find out, what that looks like around Europe. Is that sort of, how widespread is that access? Stella or Timo, can you sort of come in here and sort of set out what's happening across the region? Where can you and where can't you get access to self-tests?
Yeah, maybe I can start and then Stella can take over. So we've monitored this quite closely over the past, I would say, 6, 7, 8 years, especially when self-test came into the picture. And just pretty much where we are today with emergency department, it started with 1, 2 countries and it started spreading. And not much happened up until COVID happened. It was a handful, maybe 6, 7, 8 countries that had implemented self-testing policies. It doesn't mean that that was at enough scale, but but 6, 7, 8 countries had self-testing as a possibility. UK being one of them is always novel, implementing these novel approaches. Post-COVID, when everybody knew what a self-test is when it comes to COVID, many countries actually started implementing self-test and rapidly changed. So we monitored over time, pre-COVID to post-COVID, and it almost tripled the number of countries from quite low numbers, 6, 7, 8 countries, but over 20, 25 countries had 2 years ago. I haven't the latest data on this, but it's much more widely accepted as a tool. But still, what we're lacking is the scale of self-testing that is performed. We don't really know that. And as Jürgen said, there was some hesitancy about linkage to care. What do we do if somebody tests positive, a conformity test, and ensure that they come to healthcare settings? Those kind of concerns are always there whenever a new tool comes out to the market, right? So I would still say, as I think both Stella mentioned this, but also Jürgen, that this is one important tool. It's not the only tool, it's an important tool. Emergency departments is one tool, an important tool to reach those who actually prefer to get the self-test. They have a hesitancy to come into the healthcare system to get tested. Or as Jürgen said, they don't feel I'm not vulnerable to HIV, so I don't see myself as needing to get tested. But migrant populations, for example, find self-tests very important. But are they being reached by community organizations and public health institutes to give them these free tests? That's another question. So yeah. So basically the same pattern there as well, Ashley. That countries in the West started to implement this, but it hasn't really trickled down at scale to the further east we go. Stella, I don't know if you want to. Yeah, I see your hand up, Stella.
Stella.
Yeah, apologies. I have an issue today with the image, so I'll try to speak again off camera. Very good question about the testing strategies. Indeed, many countries have adopted the more diversified testing strategies, but I think what we are seeing from countries is a very different uptake and also very different yield, so to say, in terms of case finding. So, for example, from the countries in Eastern Europe and Central Asia that have piloted and actually rolled out self-testing, it's usually, and when they do analysis of who are the users, it's usually people who test for the first time and most likely to not be positive. So self-testing does not reach necessarily to the population that it is thought to be reaching. At the same time, actually, index testing and social network testing through community-based testing is much more productive in finding and penetrating the social and sexual networks and reaching more people who otherwise would not be reached through the conventional testing. So I think there's quite a lot of untapped opportunity to use social network testing in across Europe at wider scale than currently is. It's more, I would say, dichotomy, either facility-based or community-based, but not necessarily working through the networks the way that in some other regions work. And I think Olena can also say more, but in Ukraine, I think half of the people who are found positive, HIV positive, have been tested in communities through community-based organizations and using these case finding strategies more than blanket approaches in testing a lot of people, but without actually reaching to those at risk.
Jürgen, you had your hand up earlier. I'm not sure if it's still relevant if you want to come in.
Yeah, I just wanted to reemphasize what Ricardo was saying about the importance of linking people to care once they get tested, for example, through an emergency program. But I think that's one of the beautiful things of the UK program, that this is community led, that they have peer navigators who then make sure that people, because this is not going to happen to the emergency doctors, but so that's where the community has to be involved to make sure that people also get linked to care. I think that's a very important point. And the other point I wanted to make is around because there was a lot of focus also on having PrEP services for other vulnerable groups at risk, which may be the ones where we see more infections these days, and just highlighting that in the major countries Timur listed in his PrEP access diagram, that these over 99% of these are all MSM, which tells us that we're not very good at getting PrEP services to other groups outside of the MSM. And I think that long-acting is an important role which would facilitate the implementation of PrEP into these groups. And that's obviously a big discussion because of cost. And then thirdly, what I wanted to say is that self-test in Germany is not used very much. And again, cost is a true barrier. So I think that's one of the important things to remember, that these tests come at a relatively high price. And in some countries, testing is free. And in many countries, it isn't. And that obviously creates some of the differences. Thank you.
Olena, do you want to come in here on the situation in Ukraine in terms of self-testing, and also, then the eventual linkage to care, and how well that's, how sort of well that link is being made?
Yeah, sure. As Stella mentioned, we have, I don't know how to say correct, we have or we had, because, we have crisis in all over the world, and Ukraine is a part of this crisis with funding. If we're talking about self-testing and communities engage on this process before January 2025, it was really good, effective, and others. But now we have so many programs which roll off due the financial crisis, and now we try to use our connections with people from vulnerable groups. We also, as a national network of women living with HIV, we provided PrEP among sex workers, women who do sex work, and we have good results because they trust us more than healthcare providers. And the same things among MSM communities. They provided PrEP programs, and they were the first who started to provide this through MSM communities. That's why I would like to say, we continue to be strong and resilient, but we don't have money and programs which we had before to continue and to be strong with the numbers which we need to test in people. And you see also, as I said about IRE programs, compare from 2009, we have a lot of achievements, but we can't do this better because we have so many problems due to the war and financial issues also.
Thanks, Olena. Stella, you answered this question in the chat, but not everyone might be monitoring it. Someone asked about the decreasing proportion and number of people contracting HIV due to injecting drug use, and how was this achieved? I'm wondering if you could outline just a few of the key things that changed, or what actually we're seeing in the data here.
Yes, thank you for bringing this question to the discussion. Indeed, the epidemic is changing and very varies across the subregion. 20 years ago, the epidemic among people who injected drugs was prevalent and prevailing mode of transmission, and it led to this increased and explosive number of people affected. Over time, the population of people who inject drugs and actually the prevalence of injecting drugs has changed, has reduced. Many people nowadays use non-injecting drugs, and I think the behaviors have also improved. There was a lot of focus on scale up of harm reduction programs. Again, not the same across the region and in the countries, but many countries have improved the uptake of needles and syringe programs and opioid agonist therapy, and this has led to decrease in non-safe behavior of drug injecting. At the same time, we have to understand that the data is based on the official transmission, self-reported. It's self-reported data, and it's based on surveillance of self-reported data for modes of transmission. Sometimes, in many settings and in some countries, as already Timur alluded, drug use is still criminalized. People are less likely to report it, so some of it will be captured in a heterosexual transmission by men or women. And to be able to correct for that, there's a need of special studies and also maybe some cluster analysis. So it's a mix really of things, both of actual change towards sexual transmission, but also in some settings underreporting of drug use.
Great, thanks for clarifying that. And we have a question from Christos, who was actually a very similar question to what I had about the funding cut that we've seen both from the US as well as European countries. And the person asking the question was asking, what are your thoughts with regards to how community organizations and networks and the scientific community can, still realistically move to reach these ambitions to end HIV without that massive impact of funding? And I'm maybe also going to add to that question and ask, how things have changed over the last couple of months and whether there's been a noticeable impact in the region. I'm not sure who would like to give that a go. Maybe Timur.
Well, I can start, but I think this is really a question for Stella and Olena primarily, because most countries, and of course in the EU, we don't receive external funding, so we're not directly impacted from the funding cuts yet. We expect to be impacted in the sense that, a significant proportion of new diagnosed cases in the EU are among people who are born abroad, and a significant proportion of those come from high endemic countries. So potentially we are expecting maybe in the next couple of years that we may see increases there, depending on what the migration flows look like. That's all dependent on the migration flows. But I do want to say that from the EU perspective, and maybe Ricardo and Jürgen correct me if I'm wrong, but we've had a struggle with funding and the community organizations for many years, I would say. As long as I've lived here not lived here, but worked for ECDC and monitored this, it's always been on the topic that we don't have enough resources, especially for community organizations, to do the work that they can do and that they do so excellently. And it's always been a struggle. But yes, we have seen, especially over the past 5, 6, 7, 8 years, again, a little bit the drop off the political priority, even in the EU, where we're moving towards preparedness issues, pandemic preparedness issues, and issues like that. And our questions kind of have come up off the agenda a little bit. But in terms of the funding cuts, I think, as I said, we are expecting to see signals relatively early in the EU. But I think more directly, Olena was on this topic, and Stella, you've done some work on this together with UNAIDS. So do you want to say something more on what the potential impacts you envisage going forward?
So maybe I'll start for the region. I will say that WHO has been tracking the disruption at the global level and across the WHO regions of WHO European region was not directly impacted as badly as other regions when US funding was withdrawn. At the same time, there's an indirect impact that is likely to hit us a bit later. In terms of impact in the countries. First of all, the U.S. withdrawal or funding cuts in U.S. Global health have led to underinvestment in some of the agencies that support regional HIV response, and we are yet to see the impact on the Global Fund and how is that going to change their replenishment pledge. And but in any case, in any scenario, Eastern Europe and Central Asia, based on their criteria, is already going to see a significant reduction in the country envelopes. So we don't know how much, but it is expected that the next funding cycle, 8, is going to impact how much funding, external funding, is available to the countries in Eastern Europe and Central Asia. So while US reduced funding had disruption, and it has been quantified, and there are modeling studies and showing how many additional infections are expected or increase in mortality. I think the impact of reduced funding of the Global Fund, of UNAIDS, of WHO is going to hit a bit later the region. So we really do hope that European Union and the European countries stay in the leadership position and continue supporting the regional response. So Europe for Europe solidarity. Thank you.
Lena, are you seeing an impact already on the ground?
I totally agree with Stella that she said about funding, about cut funding, but I also would like to say about European organization, not just about organization from Eastern Europe and Central Asia. We should talk about European community-based organization, which also have cut of financial from EU, also from other, from government, and it's a very big trouble for all of us.
Ricardo, would you like to add to that?
Well, yes, thank you. I agree with everyone, and I wanted to just to focus that the EU doesn't have a plan anymore for HIV, and also to highlight the investments that are going to be done in the defense in each country, which that money comes from somewhere, and one of the places is health, of course. And I wanted as well to talk about the dismantling of UNAIDS, because it's not the sunsetting. Stop calling this the sunsetting, please. It's the dismantling of UNAIDS, which, of course, having in account that we don't have a plan in the European Union anymore, will have a profound consequence in HIV response, because UNAIDS plays a critical role in coordinating efforts, setting global targets, ensuring accountability among also stakeholders and governments. So without their leadership, we think that we might be weakening the political commitment and creating gaps of funding as well and advocacy. So this could also lead to a slower progress in prevention, treatment, and human rights, and of course jeopardize our goals to 2030 that are already at risk.
Thanks, Ricardo. I've been told I can go a little bit over time, but we are nearly at time. So I'm just going to tell you what my final question to each of you is going to be, and then I'm going to come to Jürgen for a specific question on long-acting drugs, which hopefully will be a bit more optimistic. But my last question is going to be about, sort of what is your call to action? What is needs to be prioritized now? If we're looking at one or two key things, we've had a whole bunch of recent data in the last couple of weeks, and I'm wondering what you think the most urgent priority should be. So that's going to be my question in just a moment. But Jürgen, first, we obviously have seen a lot of developments with long-acting drugs, for PrEP and for treatment. And I'm wondering, how you see these fitting into the picture of, being able to decrease diagnoses in certain groups where we're not actually reaching the targets. How key do you think that these drugs are going to be to actually reaching these ambitions?
So if you look at the effect of oral PrEP in those populations who use oral PrEP, you can see that this has led to a significant decrease in new infections. So we know even oral PrEP once daily works, but we do also know that there are vulnerable populations which don't go very well with oral PrEP every day because they have, other challenges in life which make it difficult for them to adhere to a once daily regimen. The long-acting regimens clearly promise to overcome these hurdles and to move away from the 99.6% in Germany receiving PrEP being MSM and moving to other populations, which is urgently needed in face of rising infections in these other vulnerable groups. And so I think that would really make a big difference. The only problem is the price, at least the US price currently of these long-acting drugs are very high. And that has led to sort of a delay in getting these drugs or making them available in European countries. And so that will be a fight to get prices in light of an oral PrEP, which is generically available for 30 to 40 euro per month. And I think that will be the big challenge. But if there would be some uniform European action and political power to make this happen, I'm sure that there would be a way forward. And I think long-acting will be a great way of reducing infections, particularly in the vulnerable groups where we currently see rises in new infections.
Thanks so much, Jürgen. And I'm going to come to each of you for sort of your final message to the audience in terms of, what needs to be a priority. Teemu, do you want to kick us off? I know it's a big question, so.
Yeah, exactly. I'm trying to think here several things. I would like to raise at least 2 or 3 points. One is PrEP again, like Jürgen said. There's a lot of talk along long acting, but as Jürgen said, we have oral PrEP is very effective, and we are not using it at scale. We know if we have a tool that has come down in price now. We are reaching MSM communities. Even in that community, we haven't reached it at enough scale. So there's still an unmet demand among that population. But among the other groups there, as I said, in the EU, 56% of all diagnoses are among migrants. The prevention needs to be much more directed to migrant communities, and especially migrant MSM, which is basically the only group in the EU where we're seeing increasing diagnoses. And that is something that we really need to prioritize. We keep talking about it, but I still don't see enough primary prevention programs, and especially PrEP targeted toward that population. If I want to single out one more thing, is probably the issue of stigma. So PrEP, primary prevention, and the stigma is, we have data, and we've talked about this for so many decades around stigma, and now we have hard data to show the high levels of stigma in the community, but also in healthcare settings. So, and I know there are initiatives about to start now to try and develop interventions to tackle HIV stigma in healthcare settings together with EACS, and I think that is such an important priority because with these new drugs, people are going to live longer and longer. We started the discussion about standards of care, comorbidities, etc., and we need to provide, to develop interventions to address stigma, so people living with HIV do not experience or are worried about stigma when they go to the healthcare setting. So, if there's 2 things I want to prioritize or highlight, it's the issue of migration in the EU, which is top priority. It's stigma in the full region that is still very, very high, and so I'll stop there.
Thank you so much. Ricardo, would you like to go next? And obviously, if you have the same ideas as Teemu, don't feel shy to not to repeat the same.
It will be very difficult not to repeat ourselves because we all are very in line with what needs to be done. But I would say that I will go a little bit further. I would say that universal access to testing, prevention, and treatment for everyone in Europe, it's a must. There's a chunk of people, a large number of people that aren't having access to this, and it's very difficult, to work, be it at the community level or a clinical setting, when people are not allowed to have access to these, basic tools. So I would say that this is very important, universal access to everything for everyone that are living in this space. And of course, I need to talk about stigma. We have data, but we need to produce more data, especially at a country level. We need to have tools that are simple to collect data on stigma. And most of all, we need to have strategies and programs at the European level, and of course at the local level as well, to make sure that we tackle stigma, because this is, I think, one of the last frontiers that we need to overcome.
Thank you, Ricardo. Olena, what's your sort of key priority at the moment?
I think PrEP can save us. First of all, testing, good care of people living with HIV, testing, treatment, all together. And first of all, this reduced level of stigma discrimination. Thank you.
Thanks so much. And Jürgen, you obviously mentioned the importance of PrEP already. I'm not sure if you want to add to that.
Yeah, just on top of what everyone has said, and I would agree, there would be no stigma, then HIV would treat it differently, then a lot of the problems per se wouldn't exist. But I would also really strongly still emphasize that there's a need to uniform testing policies and get rid of the written consent demands in some of the countries remaining, and really move to opt-out testing.
Thanks so much, Jürgen. And Stella, the final say.
Yes, community is at the center, because with all the changing in funding, the first and most sensitive to be decreased or reduced is actually community-based services and community engagement. So I think regardless of the scenario, funding scenario, the role of communities in responding to AIDS is crucial, and they need to be supported moving forward. Thank you.
Thank you so much, Stella. And thank you to all the panelists and to all the audience members for joining us today and for participating and for the lively discussion in the chat. And thank you very much to the ECDC for hosting this event and bringing us all together for it. Thank you, everyone.